Has anyone heard the term fistula? Yeah, fistulas. So just the general term fistula basically refers to a connection between two systems. Um, I mean, it could be sometimes there's a urinointestinal fistula where sometimes you can have a connection between the urinary system and the digestive tract. So I've seen like maybe patients who've had some sort of like radiation treatment, or even women who've had like a traumatic birth, they can actually tear, and they can create a fistula between like the urinary system and the digestive system, the rectum. You can wind up with a tear between the bladder and the rectum, and where fecal matter actually enters into the bladder. You can have fistulas between trying to think. The most common, well, some of the most common ones are involving the vascular system. So we're going to look at the vascular system. So it's a connection between two systems. You have to kind of think of the venous system and the arterial system as two independent systems working independently, doing their jobs. They have very different, as we saw before, very different characteristics in terms of their waveform characteristics. The pressures that are involved in the two systems are very, very different. So when we have a connection between those two systems, they're going to have an impact on what they're going to deviate from what they normally look like and normally present as. So we're going to learn some of the physiologic changes the physiologic changes that occur in the arterial side as well as the venous side. We're going to discuss something called Steele phenomenon, what that represents. We're going to look at potential anastomosis. So anastomosis refers to the connection sites. So we're going to look at the connection sites where that fistula occurs. Stenosis or blockages at these anastomosis or connection sites, as well as potential for pseudoaneurysm formation. So when we talk about the term specifically arteriovenous fistula, you'll often see it abbreviated AVF, arteriovenous fistula. This is an abnormal vascular connection allowing the blood flow to go from an artery directly into a vein. So in this situation, we're bypassing the whole capillary beds. So instead of everything slowing down, we have the arterial blood flow, velocities have to slow down, the pressures have to drop in order to have that blood flow not blow out our capillary beds. We're doing something that's not natural. We're taking that arterial blood flow, that high pressure blood flow, and dumping it directly into our low pressure venous system. So if you kind of just think about it from the physics perspective, we're taking something very high pressured and putting it directly into something that's very low pressure. We're going to have a very, very, very steep pressure gradient. So we're going to have very turbulent flow. So word association, when you see arteriovenous fistula, AVF, it's going to have turbulent flow, always going to have turbulent flow. And that turbulent flow is going to create something called a palpable thrill. This is our lock it up word association. When you see arteriovenous fistula, you have to associate it with this term palpable thrill. Palpable thrill. See thriller when I look at it. Michael Jackson. So palpable thrill. So this is, you can actually feel the turbulent flow. So a patient who has a known arteriovenous fistula, you're going to be feeling on their arm to feel for that palpable thrill. And that where you feel that turbulent blood flow is where that connection is between that artery and that vein. So since we have that very large pressure gradient, we're going to have elevated velocities. And that arterial waveform, normally when we're talking about our extremities, it's high resistant, triphasic waveforms. But now that we said that arteries get their characteristics based on where that blood flow is going. So now that blood flow, instead of going out to the extremities, it's going directly into a vein. So it's going into something that's very, very low pressure. So there's very little resistance now. So that arterial waveform is going to change. So as we're going down the arm and imaging that artery, say the connection's down here, the blood flow is going down the arm. That arterial waveform more proximal is going to now be low resistant. So we're going to take a look at some pictures of that. Also, now that we have all that arterial blood flow going into the venous system, it changes the venous system as well. So that venous system now becomes pulsatile. We now have arterial blood flow and characteristics of that mixing with the venous blood flow. So oftentimes we refer to the venous side of a fistula as either a mixed signal and we're able to see arterial pulsations in the vein as well. So we're going to go in depth over some of those other characteristics. So there are three types of arteriovenous fistulas. The first one is congenital, meaning you're born with it. So this happens during embryologic formation. These types of AVFs are also referred to as arteriovenous malformations. So this is present when there are many small communications within a mass of tissue. There's distinct communication jets. The distinct communication jets are not usually detected due to the presence of many smaller communications. So some places you might see an AVM. You might actually see this when you guys start scanning female pelvic exams. Sometimes there are women that are born with congenital malformations within the uterine vessels. So that's something that you might actually encounter. Second type of arteriovenous fistula is a traumatic formation. So this is usually a complication of some sort of invasive arterial procedure. So this is when we were talking about the patient maybe went for an angiogram or some sort of cardiac catheterization where the doctors went into that artery. So the artery and the vein, they're running side by side. So they went in with their needle trying to puncture and access that artery. Maybe they went too far and also punctured the vein. And since they're in close proximity to it, that blood flow now wants to go from high pressure to low pressure. It's going to get diverted into that vein. So you can create a fistula as a result of maybe some sort of complication from an invasive procedure. You could also see this sometimes also with the female pelvic exams of a woman who's status post C-section. They've cut open the uterus, remove the baby, they sew her back up. Maybe during that process of when they're opening up the uterus, they nick a vessel, and those vessels are in close proximity to each other, and you can create potential fistula within the myometrium, that muscle layer. So you can see that potentially on ultrasound. That's another place you could see a traumatic fistula. If it's not traumatic, it could also be due to physical trauma. Maybe there was a motor vehicle accident or some patient had physical trauma to a limb or extremity. And that physical trauma damages the vessels and could potentially create a fistula as well. And then there's intentional fistulas. So we do this for patients who need hemodialysis. They need to go on dialysis. Their kidneys are shot. They're in end-stage renal disease, kidney failure. They're not functioning. And we need a method to be able to filter their blood. We create an arteriovenous fistula in order to perform hemodialysis for that patient. The way that dialysis machines are set up is we need to be able to filter a large volume of blood at a very high rate. So doctors discovered they were able to create these fistulas and then tap into that venous output with their catheters and be able to drain out that blood and then put it back in at a sufficient enough rate. In terms of dialysis access, we're going to learn a couple of different types of hemodialysis methods that we use. So this is just kind of a general overview. The most common is this vesica semino fistula. So that's a connection between the radial artery and the cephalic vein. It's a side-by-side connection that's typically down by the wrist. Doctors could also potentially utilize synthetic grafts, so man-made material. So if the patient's native vessels aren't sufficient enough to use for dialysis, they can potentially use synthetic grafts, man-made material. There's different types of synthetic grafts we're going to see in a moment. There are loop grafts and straight grafts, and we'll see the difference between the two. All right, so arterial venous fistula, so the effects on the arterial side of things. So this top image, does that look like high resistance or low resistance? Oh, good, absolutely low resistance. So we have peak systolic part, and then our diastolic phase, we see all this flow. It also looks very turbulent because we don't have a nice spectral window. Everything's kind of filled in now, so there's lots of turbulence going on, a lot of mixed velocity. So we don't see the nice pretty laminar flow that we'd expect to see in a nice healthy peripheral arterial waveform. So this is very low resistance. So proximal or before that fistula connection, the artery is going to have increased velocities and decreased resistance. Red, my blue. All right, so this is just kind of to help you visualize it. So patient's hand lying there, blood flow in the arteries going down towards the hand. So if we Doppler our artery proximal or before that anastomosis, so this is our connection, this is our vein now. So blood flow in that vein, it's going to be going back up the arm in its normal direction. So taking it back up towards the heart. So the connection between the artery and vein, that's referred to as the anastomosis. That's connection. That's the connection between the artery and vein connection. Artery. So if we Doppler, if I was to take my pulse wave Doppler, try and listen to the artery proximal to that connection site, our waveform is going to look low resistant, high velocity. So low resistance and high velocity. So again, everything wants to go path of least resistance. So that arterial blood flow going down the arm, once it gets to that area where that connection is, the majority of it is going to be shunted into that venous system. But the hand still needs blood, so blood flow still has to get down to the hand. So once we get past or distal to that fistula, that anastomosis, the waveform then will change back to what we normally expect, a normal high resistant waveform. So remember arterial signals. So if I listen to the waveform down here, gets its characteristics based on where it's going. So now this blood flow, once we're past that anastomosis, it's just going to the hand. So that's normal, should be a normal looking arterial signal. We're going to see in a moment, there's some issues though. Since the majority of the blood flow is being diverted into that fistula because it just wants to go to that area of low pressure, we can wind up with that Steele syndrome where not enough blood flow is getting to the hand. It could potentially cause ischemia or a critical condition. Maybe the patient's hand starts turning blue. They might wind up with pain. We can even wind up with flow reversal where this fistula is so strong, that pressure gradient is so strong where it actually sucks blood back up the hand and just drawing it away from the patient's hand. And we can even have retrograde flow in that vessel that's distal to the anastomosis. So we're going to go over that in a little bit. So this bottom image is showing the actual connection site. So we're actually Dopplering in that anastomosis. So we're putting our sample gate, lining it up, and taking a Doppler measurement at that area of the connection site. We said that's where that palpable thrill is. So that's going to be where the most turbulent blood flow is, the highest velocities. So at that anastomosis site, that's where you're going to have your highest velocities. The highest velocities. So when we're talking about highest velocities, it's going to be both peak systolic and end diastolic velocities. So everything is going to raise uniformly. So you're going to have your highest peak systolic velocities, your highest end diastolic velocities. That's where the blood flow is going to be the most turbulent. You're going to have spectral broadening for sure, because everything is just, very turbulent at that point. You may even see bidirectional flow. So we're seeing some flow underneath that waveform from that swirling and that mixing from the turbulence. So anastomosis site, that connection site, it's going to be the area of your highest velocities. Any questions so far? So this top picture is showing patient's leg, probably up near the groin, the superficial femoral artery and the femoral artery coursing one on top of the other. And then we see an area here of blood flow connecting the two. So we're getting some mixing of colors in here. I'm seeing some oranges, some blues. So when you see that on ultrasound, that indicates aliasing. So it's velocities that are exceeding what our scale is set up to. So I know when I see that there's some sort of turbulent flow going on in that area. So you can actually see the connection between the two. So that's where that anastomosis is, that connection site is. So if I was to Doppler in this area, that's where I would pick up my fastest velocities. So this is the patient's leg, and this would be the head, feet. So blood flow is going down the leg, hitting that fistula, that connection, and then a lot of that blood flow is getting shunted into that fistula. So if I Doppler proximal or before that fistula, I'm going to have I should expect to see a low resistant, high velocity waveform, fastest velocities within that fistula. But when I get past it, I should get a return back to a more normal looking peripheral artery waveform. So something, more biphasic or triphasic. This middle image is now showing the venous flow pattern as it moves away from that AVF. So we're getting a mixed signal where it looks more pulsatile. I'm sorry, so this is as it's moving towards that AVF, it's starting to become more pulsatile. And then on the bottom is the actual outflow vein. So with that, once we're past, so blood flow is going up the leg now. So venous blood flow is returning back up the leg. As we're approaching it, it's starting to become more pulsatile. But once we've gotten past that fistula and now we have arterial blood mixing in, it's more of a mixed signal. So we can see what looks like arterial flow patterns mixed in with that venous flow pattern. So it looks a little bit different. So we definitely see the cardiac pulses, those pulsations within that venous cycle. So the top right is just showing a low resistant pattern in a connecting channel within the fistula. This bottom is just showing a turbulent pattern with the loss of phasicity within that vein. So we no longer have that phasicity or respiratory breathing. We're just seeing a more pulsatile venous waveform. So we kind of see him picking up some of the pulsations, looks like pulse, some of the pulse, heartbeat. It's a little hard to pick up. It's not a great image. So this was just demonstrating on color. So this patient actually had a fistula between the profunda or the deep femoral artery and the vein, the deep femoral vein. So when they were imaging through the cardiac cycle, they could see that the superficial femoral vein was triphasic because at this part of the cardiac cycle there was no flow. Whereas the profunda, the deep femoral vein, maintained continuous forward flow, so that would indicate the potential of something that's monophasic or low resistance. So they help use that to try and diagnose the presence of the fistula. When they actually Dopplered the waveform, they could see, high resistant triphasic waveform in the SFA. So that's normal. That's what we'd expect. But when they Dopplered that deep femoral artery, the waveform looks completely different. So we're having low resistant, a lot of diastolic flow within that DFA, as well as elevated velocity. So here it's over 40, there was in the 20s. So we have increased velocities, decreased resistance. So that potentially could indicate, the presence of a fistula. So now you as the sonographer, it's your job to try and find that connection and prove it. So they work their way sampling, trying to find the maximum velocities or the exact connection point between that artery and the vein. So here they were able to actually locate that anastomosis or that connection site, and they were able to demonstrate very fast velocities, very turbulent flow. When they were Dopplering the vein, they were able to prove that venous flow was now arterialized, so they could see the actual patient's pulse within the venous flow, or that arterialization of the venous flow. I'll be honest, fistulas that are traumatic are not very common. It's much more common for us to be actually imaging a known fistula. In terms of vascular sonography, our responsibilities are going to be to, assess the function of that fistula, ensure we're going to measure flow volumes, because that's critical when patients have to go for dialysis, determining the actual volume of blood flow that's getting through that fistula to see if it's mature enough. Because the patients will go in for surgery, they'll create the fistula, the doctors will connect those veins, and it's going to take some time for the venous part of that to mature and be able to accommodate that increased pressures. So eventually those veins are going to start expanding, become larger. The flow volumes within the venous side are going to start increasing, and we want to get to a certain point in order for that fistula to be deemed mature enough for use for dialysis. So this is just showing that vesica semino fistula. So this is the patient's radial artery and cephalic vein, and then it's a side-by-side connection. So when we actually image it on ultrasound, you're going to be able to see the radial artery, and you'll see the cephalic vein is really in close proximity. Doctors, when they create fistulas, they like to connect the artery to a superficial vein, preferentially, just because that superficial vein is closer to the surface and it's easier to access when they have to actually do dialysis. They don't want to have to go digging for something that's deeper. Sometimes they'll even move the vein up closer to the surface of the skin in a procedure called transposition. So they'll move that vein to a different location to make it more accessible. If the patient's native vessels don't meet certain criteria for measurements, they may use synthetic grafts or man-made material where they connect one end to the artery and the other end to the vein. And then they would just, when they have to do dialysis, they puncture that synthetic material and do the dialysis through the graft. So this is just showing that vesica semino fistula. Again, it's a side-by-side connection between the radial artery and the cephalic vein. That's the most common presentation. This is just showing the synthetic grafts. So some of the materials that they use. Probably the most common is a Gore-Tex type material. So same thing for like waterproof sneakers or shoes or your jackets. We use Gore-Tex here. Wow. Yeah.
So if it's not, sorry, I don't know how to phrase it, but, the AVF, if that's not for the purpose of dialysis or done on purpose, that would be something that would show up as PAD.
Yeah, potentially. So the patient might have symptoms now because instead of the blood flow getting down to the feet or the legs or whatever, it's crossing right into that venous system, or a large percentage of it is crossing into the venous system. So it's never making its way down the legs. So yeah, sure.
So they would come in with
Some symptoms of cramping. Yeah.
To
what we're doing. Yeah.
Okay.
Yeah. I'm gonna erase this real quick. Another term is AVG. So we said AVF was arteriovenous fistula. AVG is arteriovenous graft. So oftentimes in the hospital, when you see AVG, that's going to mean something synthetic. We put a graft, actually a synthetic graft, into the patients. So there's a little differentiation. So when you start scanning, you ask the patient, like, do you know if you have a fistula or a graft? A lot of times patients have no clue. They'll just go for the surgery and do the procedure. They'll have no idea. If they say they have a graft, the chances of them actually knowing what graft they did is pretty slim, or what vessels were involved is pretty slim. So you really have to be able to try and image and scan and figure them out, because some of them are going to be very tricky. So this is an example of a loop graft. So this is one of the more common ones, where they connect typically the brachial artery to either the basilic vein or the cephalic vein. Sometimes they can use that median cubital vein as well. So it's the distal end of the brachial artery loops around and connects to one of the superficial veins. So it's going to be kind of in that forearm, the forearm loop graft. So with AVGs, I'm just going to kind of put here too. So these are synthetic grafts. With AVGs, there's going to be two anastomoses. Anastomi? I don't know what's the plural by anastomosis is. Anastomosis. I don't even know. I'm not going to go down that way. Two anastomosis sites. There we go. Won't say that. What points are you going to find some plural anastomosis? So there's going to be two anastomosis sites or two connection sites. So there's going to be one arterial connection site. And one venous connection site. So this graft, this synthetic material, has to connect to the artery. Blood flow gets shunted from the artery through that synthetic material into the venous system. So there's got to be two connection sites, an arterial side and a venous side. And you as sonographers got to try and find, the connection sites, find that arterial side and find that venous side. So blood flow, again, goes from high pressure to low pressure. It's going from the arterial system into that venous system. So flow direction should be from the artery into the graft, looping around into the venous system, and then back up the vein. the images that we have to get for when we're imaging these things, we want to do the proximal artery before the anastomosis. At that anastomosis site, because that's where our highest velocities are going to be. And then we're going to image when it's a graft. We typically do 3 segments of the graft. We'll do a proximal graft, a mid graft, and a distal graft. And then we also want to image that distal anastomosis site. So we're going to take pictures of that area, Doppler that area, measure the velocities at that distal anastomosis site. And then we're going to take some pictures for that outflow vein to make sure there's no clots or anything. Everything is flowing freely in that outflow vein. So this is an example of a straight graft now. So this one goes to, looks like it goes from brachial artery straight up to either basilic vein. Yeah, so it looks like they're using basilic vein in this picture. Could potentially connect to cephalic vein. So again, you want to typically connect an artery to one of the superficial veins. Just showing another dialysis graft, so another straight graft. But it went from brachial artery to the basilic vein. So we're going to talk a little bit more, I think, next semester when we actually, or it might be this semester, when we're actually getting a little more into fistulas and discussing some of the measurements that are involved and what we measure, the diameter criteria for the vessels involved, how we determine whether or not a patient is suitable for a fistula versus a graft, and when we would do one versus the other. All right, so physical exam. So this is kind of just kind of switching gears a little bit, talking about when we do a physical exam for a patient. So some of the things that we look for when we're talking about peripheral vascular disease, when we're doing our visual assessment, is looking for skin color changes or skin changes. So the most obvious is going to be changes in color. When we're looking, we check for pallor, which is paleness. You know, does the patient look extremely pale? Rhubarb is a redness. So like we said, there's certain patients that when the legs are up, they're not getting good perfusion because they have peripheral arterial disease. But when they lower their legs down, all of a sudden that blood comes rushing back and they become very, very red. Cyanosis is a bluish, purplish discoloration. So that's patients that have, you know, significant peripheral arterial disease, poor blood flow getting down to the legs, so they start appearing bluish or cyanotic. We can notice temperature changes, so don't be afraid to actually physically put the back of your hand or put a palm on the patient, you know, feel the temperature of the legs. Just one leg feel much cooler than the other. We look for lesions when we're talking about arterial lesions or arterial ulcers. We saw those were very deep. They typically have regular borders to them, so they're smooth borders. They're very painful. We also look for trophic changes, so other physical changes to the legs. Some things could be thickened toenails, shiny, scaly skin. We look for hair loss, particularly in male patients. Do they have hair loss in around their shins or their calves? We could test capillary filling, so you can push down actually on the patient's toenail bed or nail bed to test capillary refill. So this elevation and dependency changes. So this goes to that pallor and rhubarb. So when we elevate those legs, they become very, very pale. But when we drop them down, all of a sudden gravity starts taking the blood back down and they get a sudden rush of blood and they become very, very red. So this is referred to as elevation, pallor, and dependent rhubarb. Pulses, we can try and grade the patient's pulses, palpate for pulses. Again, if pulses are diminished or absent, this would suggest arterial insufficiency. So we can palpate several different areas. When we talk about the legs, common femoral artery up in the groin, we can feel behind the knee for popliteal artery. We can try and feel for our dorsalis pedis or posterior tibial pulses. So this may not necessarily be you guys, when we're listening. So this might be more for a doctor or PAs and doing the physical exam. But listening for, the presence of a bruit. So we said bruit is caused by turbulent flow. The vibrations of that, turbulent flow along that vessel wall causes a bruit. So, bruit is an abnormal low frequency sound caused by a significant stenosis or blockage where we have those very fast velocities and turbulent flow. You can also potentially grade a bruit as mild, moderate, or severe. Where this comes into vascular, oftentimes they'll listen for bruits with the carotid arteries, maybe with the abdominal aorta. A little less common for the legs. I'm just showing some potential pulse sites where you can feel for pulses on patients. So radial, we know ulnar, just come to the medial side of the wrist. You can feel for the ulnar pulse. Brachial pulse. You can even feel a subclavian pulse. You can come above the clavicle or below the clavicle. You can do a carotid pulse on the side of the patient's neck. You can even feel for the superficial temporal artery. Just showing the common pulse sites for the lower extremities. So interventions. So the most basic interventions when we're talking about peripheral arterial disease are correcting those risk factors, those controllable risk factors. So stop smoking, go on a diet, low fat, low cholesterol, exercise, all things that are going to try and lower your cholesterol, lower your blood pressure. Potentially, if you're pre-diabetic, change your diet to try and control your blood sugar levels. So those are all considered conservative treatments. If those conservative treatments don't work, doctor may start to prescribe you medications to control, some of those risk factors. So it might be something simple as just take a baby aspirin, try and thin your blood a little bit. Percentine helps to dilate your vessels. Maybe they may potentially prescribe like a blood thinner. These would also be cholesterol medications, blood pressure medications. If those medications and treatments don't work, potentially doctor might, if you have significant peripheral arterial disease, you might have to have surgical interventions. So we're going to go over some of the different surgical interventions that patients might have to go through, but this just lists a couple, like bypass surgery, endarterectomy. If God forbid you developed gangrene, amputation, sympathectomy is when we're talking about that Raynaud syndrome, trying to inhibit the patient's sympathetic nervous response. So basically a nerve block to help prevent the constriction of those blood vessels. We'll talk about some of the different non-surgical interventions like angioplasty, thrombolectomy, atherectomy, stent placement. Right, so this is talking about peripheral arterial disease when we're talking about bypass. So if you take a step back, I had mentioned before that peripheral arterial disease in the upper extremities is very, very uncommon. It's very, very rare for patients to have chronic peripheral arterial disease in the arms. It's way, 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 way more common in the legs. So since it's more common in the legs, you're going to find way more bypass patients with bypass surgery in the legs. So the whole point of bypass surgery is to get around areas that are stenosed or blocked and try and bring blood flow down the leg to where it needs to go. So they're gonna use segments of vessels to try and get around those blockages. It's the same thing that they would do for the heart. So a patient has blocked arteries in the heart, they're gonna use segments of vessels to try and get around those blockages to bring blood flow to the areas that need it within the heart. So we're doing the same thing here in the legs. So we had said before that the GSV, the great saphenous vein, is a common vessel that's used in bypass surgery. So since we're talking about the legs, the GSV is right there. So there's actually two different options or two different methods that are utilized for lower extremity bypass surgery when we're using that GSV. The two options are going to be a reversed saphenous vein graft and then an in situ vein graft. So I'm just going to put on here LE, lower extremity arterial bypass. Using GSV. So option one is our reversed. Yeah, reversed vein graft. So with this reverse vein graft, this first picture, what they do is they actually take that greater saphenous vein, remove it out of the patient, flip it upside down, and then surgically attach one end, to the artery higher up, and the other end to the artery lower down to get around that blockage. So the reason they reverse that vein graft, or they reverse the vein, is because of the valves that exist within that vein. So by reversing it, the valves, it doesn't prevent blood flow from going down that through that vessel. So the valves are kind of always staying open. So the little valves, they're one-way valves, but when you reverse it, it allows blood flow to travel down that leg. So we're taking that vein, turning it into an artery now, and getting blood flow down the extremity to where it needs to go. We reverse it and because of those valves. So now those valves don't affect the blood flow going down that leg. So we reversed. So I'm just going to put your valves. Do not inhibit blood flow through graft. So this vein has now become a graft. So we reversed it. The valves do not inhibit the blood flow getting down that graft or down the vein now. I don't want to say vein. I want to say the blood flow doesn't inhibit, the valves don't inhibit blood flow getting down the bypass graft now. The problem with this reverse vein graft is since we've now flipped it upside down, the vein is much smaller distally down by the ankle than it is up top. So we've now taken a smaller bottom and connected to a larger artery at top. And that large piece of the vein now is connected to a smaller artery down, lower down, wherever that, it's connecting to, that bypass graft is connecting to. So the reverse vein graft has, I'm going to put size mismatch. Or how about we say connection site? How about that? Connection site size mismatch. Connection site size mismatch. That's for reverse vein graft. So with the reverse vein graft, that GSV, we have a small segment of vein connecting to a large artery, and then a large section of vein connecting to a small artery. So that can be challenging for a vascular surgeon. You're trying to connect this large vessel to a smaller vessel. And also, if you think about it, you have a small connection site up here connecting to a large artery. you're not gonna get a lot of blood getting into that smaller vessel. So you want as much blood flow getting down into that graft as possible. So if you have a small little vessel connecting, to your artery up here, there's only a small amount of blood flow getting into that graft now, or a reduced amount of blood. So that might not always be the best option. So then, in order to correct that size mismatch, the doctors tried doing something called an in situ vein graft. So in situ, they leave it inside, they leave it in the orientation that it exists within the body, so they don't actually remove the vessel. So when they connect it to the artery now, the size is matched. You have a large vein connecting to a larger artery, you have a smaller vein connecting to a smaller artery. So it makes the vascular surgery a little bit easier in that respect. But the problem is now, since we have those valves in the veins, we want blood flow going down the leg, but those valves are gonna stop that, they're gonna impede it. So with the in situ vein graft, we actually have to go in and do a procedure to either disrupt or disrupt and destroy these valves to allow blood flow to go through. So they go in with either maybe a laser surgery, radiosurgery, or they use maybe a little bit of sclerosing agent, some saline to try and destroy these valves. And they'll also tie off those perforators. So they'll close off any of the perforators that exist. So now this becomes now an arterial conduit that now brings blood flow down the leg. I'm just gonna delete this. So reverse vein graft. The valves don't inhibit the blood flow through the graft, so that's good. But the detractor, or the bad part about it is we have that size mismatch between the ends of the grafts.
So if you're deciding between the two, is that just like surgeon preference?
Yeah, surgeon preference. So we're gonna take measurements. So we'll do what's called a vein mapping. So we'll map the whole GSV. They'll know the sizes of the vessels of the different levels. So then it's up to the surgeon to decide, I think it's better if we go this direction versus that direction based on those sizes. So that's not our judgment call. It's the surgeon.
Yeah, I just didn't know if it was that or if it was like
Yeah.
based on the patient.
Yeah,
So
it's
it's probably
primarily based on the sizes of the vessels. Yep. So in situ. So in situ, the vein is left in its normal anatomic position. So with this, we have good size match. That's connections. Connection sites. But must remove valves. So we have to do that procedure to remove the valves or destroy the valves in order to allow for that arterial blood flow to course through that graft now. So this procedure is a little more involved in terms of having to go through and close off those perforators, destroy those valves, but you get a good size mismatch. Or a good size match. I'm sorry, I don't want to say mismatch, good size match. So this image is a little bit hard to see. So this is the patient's femoral artery and then the graft connecting to that femoral artery there. So it's a little difficult to determine the patency alone on grade scale, so it's important for us to use color Doppler, but we're going to get a little more into imaging. This just shows a couple more bypass grafts. So these are for patients who have abdominal aortic aneurysm. So these are ones that are common for this. So here they're using synthetic grafts. So this is just an end-to-end anastomosis. So this was a segment of the patient's abdominal aorta that was aneurysmal. And they actually, remove the aneurysmal segment and use a synthetic graft material. This is one now connecting from aorta down to the iliacs. So this would be a patient, maybe they've got a stenotic area in the aorta. They want to bypass that area of stenosis and they're getting around it. Common now is to do this native aorta where they actually put an endograft. So the graft is actually within the vessel itself. And then the aorta is kind of wrapped around it and sewn around it. So they close the aorta over that graft. So these are endoluminal grafts, or these are these grafts that are within the vessel itself. And then these are typically to repair abdominal aortic aneurysms. So this circle around is kind of just representing a patient that has an aneurysmal aorta and what they would potentially do, depending on the level of that aneurysm, whether or not, the iliacs are involved as well in that aneurysm. Get too crazy about, memorizing all these different types of graphs. Semester 3, when we get into abdominal ultrasound, talking about the aorta, we're going to talk all about endografts and the different types of endoleaks and all that stuff. All right, carotid endarterectomy. So these are all surgical interventions now. So bypass is a surgical intervention. These endografts are all surgical interventions. Carotid endarterectomy is a surgical intervention as well. So these are all done in the OR. Patients could go to surgery for these procedures. So endarterectomy. So this is commonly done with the carotid arteries, and it involves a surgical removal of that atherosclerotic plaque. So they're actually cutting open the patient's internal carotid artery, surgically removing that plaque, and then sewing back up that patient's internal carotid artery. So sometimes they also remove a piece of the vessel as well, the arterial lumen. So depending on the patient and that plaque that's in it, they may actually have to open it up more and actually sew in a patch over that carotid artery. So this, so they were able to sew it up nice and even. Patients who had endarterectomies, you'll actually see the scar in their neck. So when you're doing their carotid, you can actually visually see that scar. So again, sometimes when they remove a piece of that arterial lumen, they have to close it back up with a patch. So when you're imaging on ultrasound, the vessel might all of a sudden look very, very large or dilated where they had that endarterectomy performed. So carotid endarterectomy is the surgical removal of plaque, as well as sometimes a portion of that intimal line or portion of that vessel lumen. So I just don't want you guys to get confused with endarterectomy versus an atherectomy. So atherectomy is removal of atherosclerotic plaque, but doesn't involve surgery. So these patients don't have to go up to the actual OR. So they have to be on obvious anesthesia, bypass machine, so diverting blood to still get it to the brain. So this is way more involved than an atherectomy. All right, so now we're getting into non-surgical. So these are typically done in the cath lab. Patients typically still awake for these procedures, so we don't have to, knock them out for these types of procedures. So the first one is an angioplasty. Some people might have heard it referred to as balloon angioplasty. So with angioplasty, what we're doing is we're inserting a catheter into the patient's artery. So we're typically going into the groin and then snaking that catheter to the area of stenosis or blockage. And on the tip of that catheter, it has a balloon that's inflated. So this balloon inflates repeatedly, multiple times. And basically it's just smushing that atherosclerotic plaque up against that vessel wall to try and open up and make the lumen, the inner part of that vessel, wider, more patent, to allow for more blood flow to pass through. So this balloon, it's put the catheter into the groin, snake it to where the blockage is, and then we start inflating. The doctor will inflate that balloon repeatedly, and it'll smush that plaque up against the wall. This is just showing, like side of the plaque with the catheter with the balloon on the tip of it. They inflate the balloon about anywhere between 2 and 10 times to try and smush that plaque up against the wall. And then when they remove that catheter, hopefully that vessel now is wider, the patent lumen is wider and allows for better blood flow to get down the leg. So angioplasty or balloon angioplasty. This is just showing some of the different sizes and shapes of the balloon catheters. They come in various sizes depending on what vessels, the length of the disease, segment of the disease.
How long would that balloon stay in there?
It's just for the procedure, so they just inflate it a bunch of times, to try and open up that artery. So they get,
But like, it doesn't have to like stay like that for a while.
no, just inflate and then it deflates. Like they do it a couple of times, like
Okay.
to try
Isn't
and.
it like a permanent fix, like, or will it flat come back down?
That's a good question. So so unless the patient, if the patient doesn't do anything to change their life,
Right.
Yeah, then
Obviously,
whatever
like,
disease
more-
affected the artery the first time is gonna affect it again.
Right.
So now, they've
Like a
gone
fresh
into,
start.
yeah, it's not, they're
Kinda.
improving it. So that plaque is not, it's still there. There's still some plaque there,
Right.
So yeah, if the patient doesn't do any sort of corrective measure to improve their lives, it's just gonna,
Right, come back, yeah.
restenosis. Yeah, it'll come back.
So
Oh. No,
would the cardiologist do this, or would like a nurse, like someone?
a vascular surgeon or a cardiologist. Yeah, it has to be a doctor. Yeah, we're not doing this.
Oh, no, that's.
No.
But it could
Will we be,
shift out.
will we be a part of it? Like, how would they?
Is it guided?
Yeah, is it guided?
Usually it's guided under fluoroscopy.
Okay.
So with an X-ray and contrast, just because that's more real time, they can see the vessels better. Particularly if it's anything abdominal, when they have to stent anything like, celiac artery or SMA or something like that. Us on ultrasound, that's hard for us to see.
Okay.
Yeah, it's typically done under fluoroscopy, under X-ray guidance. We're diagnosing, we're finding those blockages so they know where to go. Like we play a big part of that. And we're also vital for after. So we see, the effects. We were able to ultrasound where we come in is we can determine the physiologic effects on that patient. So like we know there's a blockage. We could tell how much blood flow is getting through. We can measure the degree of stenosis. And then we can get them after the surgery and we're like, all right, yeah, we have to see a big improvement now. The patient's much better. So we might do this, our PVR SLP. So we might get really crappy results the first go around. They go in, get an angioplasty, they come back, and then we just do an ankle brachial index. They went from like 0.5, now they're 0.9. Well, that's a big improvement, and they go from disease to almost normal, So that's where we come in, is we can tell, how successful that
Wow.
intervention was. So this is another non-surgical procedure. So this is called an embolectomy. So we said that embolism in the arterial system is an acute thing. So it happened really fast. This patient all of a sudden has a clot in their artery. So we said also that clots in the arterial system are typically cardiac in nature. Maybe the clot was in that patient's heart, got ejected from the heart, went into the aorta, is traveling through their arterial system, and then keeps going and going and going until it can't go no more and gets lodged in a vessel. These arterial clots, these emboli, they're still soft. Since it's an acute thing, it's a blood clot, it's soft. We can actually puncture through it. So with this embolectomy, what the doctor's doing is they're taking that catheter, they're puncturing through that soft clot, going past it with the catheter, and then they inflate the balloon, and then they withdraw the catheter and they're pulling that clot with it. So it's kind of like sticking it through that clot, inflating that balloon, and then you can draw it out.
It will just come out and then
Yeah, so like I kind of think of it like almost like if you've got a big hairball in your drain, you're sticking a coat hanger through and you're trying to pull it out. Like
How is
so,
that not surgical?
They're still awake, so they're still like, it's not, they're not actually in the actual OR. I mean, it is a sterile field and everything, but like, you know, patient isn't knocked out for this. It's not.
I would have to be done like as soon as they find the ambulance, so it doesn't, like, what's that, get more urgent?
It is pretty urgent. Yeah, it's pretty time sensitive. I mean, particularly if like, you know, it's, say this is a renal artery, you don't want to compromise the kidney for too long. You know, so yeah, this is definitely time sensitive. So they want to get that patient into that IR suite, you know, as quick as possible.
Where would they go in through?
It's usually the groin, usually coming from artery. That's the entry site for most places. Now they're starting to do more radial artery. Particularly anything upper extremity, less distance to travel. It's easier to close this off. You have to hold less pressure. They actually have a little device now that they just clamp to the patient's wrist now, so the nurse can go about their business rather than having to have someone hold pressure over the patient's groin for, 30 minutes. Yeah, those in the cath lab, the poor PCAs, like they get worked because they're the ones that are typically holding the pressure on that patient's groin for like 20-30 minutes or even longer, depending, and the patient's all bruised up and yeah. Gotta do what you gotta do. All right, so that's embolectomy. So this would be, and if patient's got acute embolus in the arterial system, they would do this embolectomy. Atherectomy. So you look at that word, you can see atherosclerotic or atherosclerosis. So this is the hard atherosclerotic plaques that have built up over time. So this would be someone with chronic peripheral arterial disease. So with this, it's a modified catheter tip that's actually designed to scrape out that plaque. Some of these catheter tips actually have a suction device on it to prevent any of this atherosclerotic plaque from, breaking off and going down the leg. So this gets injected in, and it actually, some of them spin to scrape that plaque, so kind of almost like a rotor-rooter. So this thing's got like a blade on it that spins, scrapes this plaque up, breaks it up, and sucks it into the catheter tip. And then once they've removed enough of the atherosclerotic plaque, they can actually remove it from the vessel lumen. Some of these video links are actually kind of cool. Like if you ever get a chance to watch some of them, some of the YouTube videos. We can even use laser now to break up some of these atherosclerotic plaques. The vascular stents. So we've gone into the groin. We're in the groin. We've done the procedure, either an angioplasty or an atherectomy. We've done the work. We've cleaned out some of that plaque, or we did the balloon angioplasty, opened up that vessel. The doctors may say, all right, we've done all this work now. Why don't we go in there and put in a stent to try and keep that vessel open as much as possible or as long as possible? So they might introduce these mesh vascular stents to try and keep that vessel open. This is often common when we're talking about critical vessels that are supplying blood flow to organs. So like maybe renal arteries, some of our mesenteric vessels, hepatic artery, carotid arteries, definitely for sure. We want to keep these vessels open as long as possible. So we've gone in, we've done the work, we've done the hard part. The doctors may decide to put a stent in to try and keep that vessel open. So stents are they're easily visualized on ultrasound. So that's the nice part. So you're imaging your vessel and you'll know what a normal inner wall looks like, or vessel lumen. And then when you see a stent, they're very, very echogenic. They're very bright. And almost, you can tell it looks man-made, like it's not natural. You can also, depending on how you angle on it, you can actually see the mesh material of that stent as well. In transverse, you're very easily distinguishable in transverse as well. You'll typically see those circles, the ribbing or the dots around the stent in transverse. So some stents actually are also coated with blood thinning medication or some sort of medication to help prevent the development of clots as well. So pseudoaneurysm. So we talked about a consequence of a patient who's gone for some sort of cardiac catheterization or some sort of medical procedure where they've gone into the groin to access the artery. A complication of that could be the development of a pseudoaneurysm. So there are two, well, there's actually three ways, but the two main ways to correct a patient who has a pseudoaneurysm could be manual compression, so continuing to hold pressure over that pseudoaneurysm to try and get it to completely thrombose and close off the vessel. Or we can do a procedure where we inject thrombin. Sorry.
Right, I don't do a lot.
So what was I saying? So we have manual compression, hold pressure over that pseudoaneurysm to try and close off the vessel. Or we could potentially do a procedure under ultrasound guidance where we inject a medication called thrombin into the actual pseudoaneurysm to cause it to instantly thrombose and clot up, which seals off the vessel and stops the bleed. Again, depending, what determines which one they do is the size and location of that hematoma, that actual active bleeding part, as well as the diameter of the neck, the length and diameter of that neck. So we said if that neck is too wide and too short, they can't do that thrombin injection. They would have to attempt holding manual compression. I know for me, for instance, we had a patient who had a pseudoaneurysm in their arm. And we were trying to hold a compression. So like they were in the ICU and pretty much every day we'd go up and try and do compression like under ultrasound to see if we can get this thing to thrombose, and we just couldn't. So eventually, you know, if these don't work or if we can't do a thrombin injection, and manual compression doesn't work, they may eventually have to go to surgery to actually close off that pseudoaneurysm. So that's that kind of third option. That might be a surgical intervention to try and close it off, but yes, that's yeah. So there are closure devices that they can try and put in. So it almost looks like a little balloon patch that inflates and then closes like a plug almost.
It's inside, right?
It's inside, yeah. I saw one time they screwed up with that plug and they actually closed the vessel going down the leg. Like they didn't insert it right. I was like, oh dear God. Anyway, this thrombin injection method is very, very effective. And you will be involved in that. So when you guys do your clinical rotations, you absolutely will be seeing these thrombin injections performed. So with us into the ultrasound with the pseudoaneurysm. So this is a transverse view. So our native artery appears as this little circle. There's going to be a little neck that connects to this larger hematoma. So this is the actual bleed that's going on. With this, the doctor is going to image and they're going to insert a needle. So you're just going to be at this point either holding the probe for the doctor or just operating the machine. So they might just take everything themselves. They're going to have, you're going to see a little needle coming across your screen and you're going to be looking for that needle tip and telling the doctor, all right, you're in the actual hematoma now. It's okay to inject. And they're going to inject that medication, that thrombin medication into this part that's actively bleeding. This is going to become completely thrombosed. So this is also showing a color picture after the procedure. Now there's no blood flow in there. It's completely thrombosed, and that's going to close off and seal off that vessel and stop the bleed. I think the next slide, here you go. So this is a little bit better picture. So this is that needle tip. So you can actually see the needle. It's very epigenic, very bright, entering into that pseudoaneurysm. So here's the native artery further down. And then this is after they've injected that thrombin medication. Now it's completely stopped bleeding. You're gonna have your color on to be able to see that there's no more blood flow within it.
How long does that take?
It's instantaneous. It clots up in a second. Yeah.
Oh.
Yeah. So it's like the injected, boom, boom, done.
How do you ensure it doesn't go farther than?
Then when it should?
Yeah.
It's a good question. So you're after this is thrombosed, you're gonna then take a picture of that native artery a little bit further down to show that it's still open and still patent. That is a worry for sure. The doctor, before he leaves, if he's a good doctor, he's gonna also feel for a pulse on the top of the patient's foot. The patient, you're with them after the procedure. If they start complaining, oh my God, my leg is killing me. Take some pictures, figure out your ultrasound machines, try and image the artery just to make sure there's blood flow. You know, because if that is an issue, then they have to go right, you know, for some sort of surgery to try and correct that.
Oh.
Or they might have to try and reverse the thrombin.
Does your color Doppler cover the like activity of the needle, or will you be able to see it? Like, will it be like white, shiny blue color, or no?
So yeah, that's actually a very good question. So when you're gonna take color off when they're actually putting the needle in. So you want to, yeah, that's actually an excellent question. So this is just kind of showing like the needle with the color on. So while they're inserting the needle, you're not going to have any color on because you want to see that needle tip. You want to know exactly the color will cover over that needle tip. So you want to be able to see the needle tip and where you are exactly. So yeah, you'll take color off. And then once the doctor's in and he's good, he's not going to move. So it's going to be in place, and then you'll put your color back on and he'll start injecting that medication. You'll see it as it thromboses. And then, you know, he'll remove the needle and you'll stay on it to ensure. You'll scan through it. You'll take pictures showing it's completely thrombosed. So you'll be like, you know, pre and then post. And then part of your post images, you're also going to be imaging that native artery further down to show that there's blood flow. This patient after the procedure will actually come back to your vascular lab typically the next day to ensure that it's still completely thrombosed. There are some occasions where you might have to inject it twice. If you inject it a second time, that's usually the end of it. So, you know, particularly if one that's very, very large, they may have to inject it twice. This is just showing pre and then post thrombin injection. The boards, I know. So this was 1 year or 2 years ago, maybe. One of the questions was, I don't know, I have to ask the people who just took it. They asked about the needle, where that needle is placed for a thrombin injection, where you want to put it. So it was like, you know, away from the neck. So when the doctor's putting in their needle, proper placement is as far away from that neck as possible, as far away from that native vessel as possible. So they give multiple choices, like in the neck of the pseudoaneurysm, close to the neck within the hematoma, far away from the neck within the hematoma, and then like within the native artery, some ridiculous answer, you know. So the correct answer is replacement is as far away from within the hematoma, as far away from the neck as possible. So they're typically gonna be more superficial, so somewhere in that upper part of that hematoma is where you really want to place the needle tip when they're injecting this. So it's a very, very small gauge needle. So patients might be like, am I gonna get a little numbing medication? No, you're not gonna get numbed up. They just go for it. Hopefully it's not too deep. So this is again, just showing a nice bidirectional flow. So this is your typical flow pattern in your pseudoaneurysm. You get that very fast forward flow and then that flow reversal. So that get in and out, you can kind of see a little bit of that yin yang flow pattern within the actual pseudoaneurysm, the hematoma part. This was nice. This patient's transducer has a guide on it. So there's a little clip that some places have that clip on the outside of your transducer. And then when you put the guide feature on, it puts this track line. So it'll actually show you, because like the guide on the clip on the outside of the probe, you can put the needle through that clip, through that needle guide, and it guides it in a straight line. So you know exactly where that needle's going. So some places will use that for biopsies and procedures. Some places, some doctors don't, depending on the doctor. I had this one guy, Dr. Han, he was like, Dr. Han, I don't see the needle tip. He's like, nah, I think I'm in. I'm like, all right, are you sure, Dr. Han? Yeah, no, I'm good. Because he did all on his own, like I'm like, he's spanning through, scanning through. I'm like, I don't know, Dr. Han. He's like, nah, I think we're definitely in. And then he did check the thrombin and be like, yep, knew it. Told you we were in. So he was just kind of going by touch. You're a rebel, man.
Oh,
So again, you guys aren't going to be the ones actually as students holding the probe and trying to find the needle tip. So for DMS, we have sonographic procedure comp. We want you guys familiar with some of the basics that are common in all these sonographic guided procedures. So that's involving, you know, the setup, creating the sterile field, not disrupting the sterile field, obtaining consent. So all these procedures, you have to obtain patient consent prior to doing that. So I want you guys familiar with how to, you know, create the forms and paperwork for obtaining patient consent. With these procedures, there's always a timeout part of it, where before you actually do it, you take the sonographer, that's usually one of their roles too, is doing the timeout, where you verify the patient, verify the procedure, their location of the procedure, everything, you know, that what we're doing, the correct side, correct patient, and then the doctor proceeds, you know, doing the procedure. So I want you guys familiar with doing the timeout. And then the post cleanup, you know, what you have to do, properly disposing of the sharps in the proper containers. If there's any medication involved, you know, in this case, there was thrombin involved, disposing that in the proper, like, you know, receptacles for getting rid of any of these medications. Maybe there was one of the biopsies, they used some numbing medication, where to properly dispose of that. So yeah, so don't expect that you're the one that has to actually do any of these procedures at this point. We just want you observing and then being familiar with the steps that are involved. So embolization. So when you look at that, don't get you can see the term embolize or embolus, or don't get confused with like the actual embolus of a clot traveling to an artery. So an embolization is a procedure where we're actually intentionally clotting off an artery to control bleeding. So sometimes you might hear this as referred to as a coil embolization or a coiling. So with this embolization procedure, we can either use a substance, some sort of thrombolytic medication, or a mechanical device or chemical material to occlude or drastically reduce blood flow within a vessel. So this embolization procedure, we use it to control bleeding. So a patient might have a gastric bleed, a GI bleed. They want to stop that bleeding, they're gonna take their catheter, go to the area of bleed. And try and embolize or clot off or cauterize that vessel to stop the bleed. We might do this particularly if a patient has a brain aneurysm, they're bleeding within their brain, we want to stop that bleeding. They'll go to the area of the bleed within the brain and try and embolize or clot off or reduce the blood flow within that particular vessel. It could also be used to reduce blood flow to tumors. So a patient's got a cancerous tumor that's very, very large, they might want to try and shrink the size of that tumor. They might embolize the feeding vessel to that tumor to try and reduce the size of it. This could be used for patients that have arterial venous malformations, those AVMs. So they want to correct that arterial venous malformation, they'll close off that feeding artery to that arterial venous malformation. Can be used as an operative procedure to stem blood flow to a particular site as well. So we want to try and shunt blood or direct blood to particular areas. So follow-up exams. So we often do follow-up exams when we're talking about vascular studies. So we can bring our duplex scanner into the operating room to increase the quality and specificity of a procedure by detecting abnormality immediately. Potentially detecting abnormalities at the end of our operation or procedure. We also do serial follow-ups. So with this, we can detect stenosis after we've done a surgery, after follow-ups to see if people are becoming re-stenosed, if those blockages are redeveloping. So this helps to improve long-term patency of the procedures that have been done. Wow. Okay. You guys all know this, right? So. Endarterectomy, surgical removal of atherosclerotic plaque. Atherectomy, non-surgical removal of atherosclerotic plaque. Those bypass grafts for the legs. Reverse vein graft. We have, unfortunately, we have a size mismatch. So that's one of the detractors of doing that. But we don't have to worry about the valves being an issue with the reverse vein graft. In situ graft, we have good size matching in terms of the vessels, large end to large end, small end to small end. But we have to go in and do a procedure to disrupt those valves and tie off the perforators. Talk about palpable sites, the grafts. Cool. I want to try and knock out a couple of these from week 5. So these are non-invasive arterial tests. So one of the subcategories of a non-invasive arterial test are something called physiologic tests. So what we were doing back there, that PVR-SLP, this is considered a physiologic test. So it's indirect, it's a non-imaging test. So when tests are referred to as indirect, that means that there's no actual physical images of the vessels themselves. Indirect. Direct tests. We can say it's non-imaging. So it provides physiologic information to determine the presence or absence of arterial occlusive disease. So we can see some of that, we get some of the information, we can see the effects of that disease on the pressures. We can see the effects of the disease on those pulse volume recordings, so the amount of blood that's displaced in that cup. So we could see physiologic information that helps us determine the presence or absence of disease, but we don't get direct imaging. So we don't get direct images of those tests of those vessels. So we can't pinpoint the exact location of the disease with indirect testing. So it's a good first step. We can say yes or no, there's disease. You can get a general idea of the location of that disease, but we can't pinpoint the precise spot. Advantages of these physiologic tests, they're simple to perform. The testing time is pretty short, particularly if you're just doing an ankle brachial index. You just put an ankle cuff, you put your brachial cuff, get your ABI, and you can get a good first step or first answer. They're accurate for a disease that's hemodynamically significant. So if the patient has significant disease, we can pick that up. But if it's just very mild disease, it might be harder. The early onset of disease, we may not necessarily pick up those changes. It's non-invasive, so it's good for follow-up, easy for follow-up. Provides objective, quantitative, physiologic information. And the equipment's relatively inexpensive, you know, when compared to like an MRI machine or a CAT scan machine. So our machines are, you know, definitely less expensive, and the cost of the test is also less expensive. The limitations for our physiologic tests, again, like I said, we can't identify the precise location of disease. And we tend to make general diagnoses. So we say mild, moderate, severe, you know, we kind of group it into more broad general terms rather than assign a specific, you know, degree of stenosis. So we can't say, oh, it's, you know, 50%, 60%, 70% stenosis. We can't see the actual vessel, so we can't determine the degree of diameter reduction or the degree of stenosis. So it's more general terms that we use. So this is just showing with the lower extremities, we break up the arterial segments into different systems. So we have an inflow system. So this is the vessels that are flowing into the leg. So I say kind of into the groin. So basically everything like the infrarenal abdominal aorta, common iliac, external iliac. Those are all inflow. So this segment is the inflow vessels. So I kind of, the boards likes to have you be able to determine or distinguish between inflow disease versus outflow disease versus runoff. So the inflow segment are the vessels that are flowing kind of into the groin, into the leg. So aorta, iliac, Outflow, it's the blood flow flowing out of kind of like the groin out to the extremity, so it's common femoral popliteal. So then once you get below the level of the popliteal, this is now tibial peroneal runoff. So that's our peroneal and posterior tibial vessels. So I say flowing into the groin, out to the leg, and then runoff is, the calf vessels. So anything below the popliteal is runoff. So in terms of physiologic tests or indirect testing for arterial tests, we have plethysmography, segmental limb pressures. We have that treadmill exercise test and another one called reactive hyperemia. So we've done plethysmography and we've done segmental limb pressures. So the first part of the test that we were doing was that pulse volume recording. So this is a form of plethysmography. Plethysmography measures volume changes, volume of blood flow changes. We also use those little clippies, the little sensors for the toes. So this is called PPG or photoplethysmography. So we'll see in a moment, this photoplethysmography, PPG, is not a true form of plethysmography because we're not really measuring volume changes. We're just using the infrared light, whereas the pulse volume recording is a true form of plethysmography. So plethysmography definition measures volume changes in the extremities. So that PVR, that first part of that test, the pulse volume recording, we can use that to differentiate true arterial claudication from a non-vascular source. It can be used to document the functional aspect of this arterial disease. Again, detects the presence or absence of arterial disease. We can use those waveforms, those PVR waveforms, to help us localize the level of disease or obstruction. And we can also assess the patient after any sort of medical treatment and or exercise therapy. So our pulse volume recordings, some limitations, it's not specific to a single vessel. So we have our, say for instance, our thigh cuffs, we have our femoral artery as well as the deep femoral artery there. So we don't know if the disease is, relegated to one or the other. Think about your calf cuff or your ankle cuff. We have multiple vessels that are going on there. So we might pick up reduced blood flow, but we don't know which of those calf vessels, could potentially be the ones that are really diseased. So it could be anterior tibial artery, it could be the posterior tibial arteries that are bad, it could be the peroneal arteries that are bad. So we don't specifically know as a result of our pulse volume recordings. So we can't, it's not specific to a single vessel. It's less diagnostic and isolating, the disease location than if we used a Doppler. Again, unable to discriminate between major arteries or collateral branches. So maybe the patient's got good collateral circulation and their major vessels are the ones that have significant disease. We can't really tell. It's also difficult to perform on obese patients because the larger the limb size, the less displacement of air in that cuff because we're not really picking up those pulsations of that pulse. So we get much smaller waveforms. It's harder to detect on obese patients. Our preparation, we want to keep the room nice and warm, comfortable. The patient supine. So there are a couple different forms of plethysmography. So these other ones are a little bit older. The one we use is our pulse volume recording and our photoelectric plethysmography or photoplethysmography. So this is using those little clippies, the infrared sensors. Just recognize that photoelectric plethysmography is not considered true plethysmography. So it doesn't truly measure the volume changes. So some of these, I'm just gonna kind of go fast through these, because, you know, just for the sake of completeness, because, the board may throw some questions on some of these older equipment. So this is an older form of plethysmography that, uses an air-filled, recorder, to record those pulsations. So a pneumatic cuff or pressure cuff is placed around the specific levels. Cuffs are inflated between to 10 to 65 millimeters of mercury. So this works on the same principles as the PVR, the pulse volume recordings that we do. So the pressure is converted to an analog meter that's recorded to a strip that records those volumetric changes. So more important is what we do, is our segmental volume plethysmography, or PVR. So the pulse volume recorder records a difference in limb volumes, so the blood flow in and out that occurs in each cardiac contraction. So with our pulse, we're measuring the volume in and out, and we get those waveform tracings. We can detect the volume and the volume pulses as the blood moves through the extremities with each cardiac cycle. And we can get qualitative assessment of the overall limb perfusion, or the overall amount of blood that's coursing through that limb. So these are valuable. So these waveforms that we get, this first part of this test, this pulse volume recording, it's very, very valuable information that we get, particularly when we have diabetic patients where their pressures are falsely elevated. So we have vessels that are non-compressible and we can't get an ankle brachial index, or we can't compress those vessels to look for drops in pressure. We can tell the presence of disease based on these pulse volume recordings. So these PVR waveforms will help us to determine if there's presence of disease and the potential level of the disease when we can't obtain pressures. So patients who are diabetic, they suffer from a condition called medial calcinosis. Those arteries have become so hard, so calcified, they're non-compressible or incompressible. We can't obtain pressures. We rely now on these pulse volume recordings in order for us to get some sort of information out of that exam. So that's why we do the two in tandem. We do this first, get our pulse volume recording waveforms, our plethysmography waveforms. Off of that, we can kind of get an idea as to whether or not, you know, this patient has disease or not, kind of what we're in for in terms of pressures. And then we move to that second part of our exam where we get those segmental limb pressures. Again, with our PVR waveforms, the cuff width, the width of our cuff should be 20% greater than the limb diameter, or 40% of the limb circumference. We wrap those cuffs on different segments of the extremities. So same thing when we discussed before about a patient's symptoms, or if they're having cramping or pain in a particular muscle. The segment of the artery that's diseased is going to be proximal to or at the level of the cuff that shows the abnormal waveform. So eventually, when we looked at our report, our preliminary report, we had our nice waveforms. We can recognize, normal looking PVR waveforms versus something that's a little more abnormal. So as the disease starts to progress, they start becoming more flatter, elongated. They start looking more like pyramids. So what that's saying is that we can tell where that disease is based on the changes to those pulse volume recording. So the disease is going to be proximal to or at the level of that cuff. So this is the low thigh cuff. If at the low thigh cuff, I'm getting something that looks abnormal compared to the cuff above it, which looks more normal, that disease has to be somewhere between those two segments. So it's got to be proximal to or above that cuff. Since this top cuff, looks relatively normal, we know that disease exists somewhere in between those two cuffs. If this top one was abnormal as well, if we got something that looked abnormal as well, then we know that disease has to be at or proximal to that cuff. So we gotta pick a disease segment that's, more proximal. So that's kind of how your board questions are going to ask you. They're going to want you to be able to look at the waveforms, look at your pressures, and then try and determine which vessel could potentially be involved. They'll give you a list of like common femoral artery, external iliac artery, aorta, popliteal artery, posterior tibial artery. So you can automatically exclude ones that are distal. So like, if you're getting waveforms like that, the disease is going to be at that high thigh cuff or even above it. You can automatically on your test cross off popliteal artery, posterior tibial artery, peroneal artery, anything more distal. So anything below that, even SFA, if it's high thigh cuff, if it says like distal SFA, that's incorrect because the disease segment has to be at that cuff or proximal. So they may give you patient symptoms as well. Patients experiencing this kind of symptom. Where could the potential disease be? So when you're talking about the arterial symptoms, so it's wherever they're experiencing their pain or more proximal. So these pulse volume recordings, they can be done on the upper extremities as well as the lower extremities. So we can get waveforms for both the upper extremities and lower extremities. Again, upper extremity PVR is much less common than lower extremity. But if you had to do it for the arms, they place an upper arm cuff, a high forearm, and a lower forearm cuff. When we're doing the legs, we typically do the 4-cuff method. So we place a cuff for the arms to get our brachial waveforms. And then we do a high thigh, low thigh, calf, ankle, and metatarsal. And then we could do the great toe if indicated, and when we use our photoelectric sensor. So if you guys notice, they typically inflated to around 65, maybe 70 millimeters of mercury, and then slowly deflated. They held that pressure. Typically, we calibrate the size of our waveforms based on what we get in the brachials. So Christiana Vascular loves to do that. We do the brachial, we get our waveforms for our brachials because again, those shouldn't have disease. We calibrate the size of that waveform based on our brachials. So we adjust that to get a nice waveform for the brachials. And then we leave it for when we're assessing the legs. So just showing the cuff placement, which we know. Some places may do a 3-cuff method, where it's a single thigh cuff. So the arterial waveforms, when we're looking at these plethysmography waveforms, here's a normal pulse volume recording waveform. So we expect to see a nice rapid upstroke coming to a nice peak, a rapid downstroke as well. So this is following, our cardiac cycle, fast upstroke, fast downstroke. And we also look for a dicrotic notch. So we get this reflection backwards or bending backwards during that diastole or the start of diastole. And then we also get a gradual runoff. So this is just kind of showing, PVR interpretation. So we said we kind of grade things as, normal, maybe mildly stenotic, and then occlusive or severely abnormal. I'll show you guys, some of the forms that they use at Christiana, in terms of when they're interpreting these waveforms. So normal waveform, fast upstroke, fast downstroke comes to a nice peak. We have our dichrotic notch. So one of the first things that we lose once a patient starts developing disease is, we still have a fairly fast upstroke. That downstroke or diastole portion starts to elongate. And we lose our dichrotic notch. It becomes flat over here, or even bending out in the opposite direction. So it's going away from that baseline. So that's one of the first things that we see as these patients start developing peripheral arterial disease. And then as the disease gets worse, if it's moderately stenotic or moderately diseased, starts becoming more rounded or more like a pyramid. And then that, as it gets worse and worse, it becomes flatter and flatter, until eventually, if the patient has a completely occluded disease, it's, you know, completely flat. There'll be no evidence of any sort of arterial pulsations. Again, so we can use those waveforms to help us to try and identify the location of the potential disease. So if the high thighs are abnormal, the disease has to be at that level of the cuff or above. So, so if it's the high thighs that are abnormal, then it could potentially be iliac stenosis. Should be at or below high thigh. Yes, all right. So if the high thighs are abnormal, the rest of the leg is going to be abnormal. So we're going to get abnormal waveforms all the way through. That's another thing to also consider too. So you're never going to have an abnormal high thigh and then a normal looking low thigh, calf, or ankle. So once you have disease here, it's going to affect all the way down the leg. So if your PVR waveforms are abnormal at the high thigh and below, it's going to be iliac stenosis or external, think external iliac, could be common femoral, could be aorta as well if it's bilateral. We're going to go over this more when we get into like actual doing more of these interpretations. If it's normal at the high thighs, but abnormal at the low thighs, could potentially be SFA or femoral artery. If it's normal at the high thigh, low thigh, but calf is abnormal or ankle, could be mid-popliteal disease. It's just kind of breaking down. So if you have an abnormal metatarsal cuff, you know, could be tibial artery stenosis. So limitations for these pulse volume recordings. So distal disease is hard to predict or hard to determine if the patient has proximal inflow disease, because we have disease high up that's affecting all the other waveforms, like through the extremities. It's hard for us to, you know, really determine the level of other disease or multi-level disease as a result of that. So it's hard for us to really tell if the patient also has disease in some of these other places, because we have something higher up that's affecting those waveforms as well. It's also sensitive to motion. So patients who have tremors, restless leg syndrome, they can't stay still, it will affect your waveforms. So PVR monitoring, it could be used intraoperatively as well during reconstructive arterial surgery. It can be used in the recovery room after surgery to detect changes in flow. These are some of the very, very old machines. That's the one that's buried in the corner over there that we didn't even use. Our old machine. And then we got a more modern one now. So this is just showing normal plethysmography pulses. So you can see in the fingers, the calf, the toe. These are again some more normal looking PVR waveforms. The PVR waveforms below the knee usually demonstrate an increased amplitude. This has to do to the coming together of some of these vessels when we get below the knee. So again, for my exam and for the board exams, they're not going to try and trip you up. It's going to be very obvious, normal versus abnormal. So you can see you've got your nice fast upstroke, fast downstroke, coming to a nice sharp peak, obvious dicrotic notch versus something that's abnormal. You know, it's more blunted, a lower amplitude, much lower amplitude, so the height of it's much less. We get a much elongated waveform, loss of that dicrotic notch, and then something that's, you know, severely abnormal. Again, so you can see normal versus mildly abnormal. So first thing we lose that dicrotic notch versus something that's moderately abnormal. So now we're getting more towards like those pyramids, and then severely abnormal is when we can still pick up a little bit of a pulse. So one pulse, another pulse, another pulse. So as it gets more severe, it becomes flatter and flatter and flatter. So these two waveforms, so they both have, you know, fairly good amplitudes, you know, fast upstroke, fast downstroke. But this one, we don't have that dicrotic notch. So we've lost that dicrotic notch. So this would be an abnormal waveform. We've lost that dicrotic notch due to the presence of some collateral vessels. Yeah.
On the slide before, the one that was moderately abnormal, it has like two tiny more not using and one above it. But so like at what point does the amplitude being smaller and get less important than the dicrotic notch?
The dicrotic notch is the most important thing to determine normal. So it has to have, in order to say normal, we have to have that dicrotic notch. That's basically the first thing. That is the first thing that we lose. Another thing too is when there is disease, it kind of goes right into the next one. So here we have a little bit of a runoff, so we get a little bit of a pause between them. So you'll notice that as well. Like once you start developing disease, that diastolic portion, we don't get a nice pause. I don't know if you guys noticed when we were doing the upper extremity waveforms, they look a little bit different than the lower extremity waveforms. Our dicrotic notch is situated higher up when we're doing our upper extremity waveforms. These are normal upper extremity PVR waveforms. These are nice, normal, healthy looking lower extremity. This is what most of us look like when we're doing it. Some more normal looking waveforms. I could see a bending back, that carotid notch, there's bending back there. This one's a little bit harder to see. That one.
So if this were on a test, would you give us like all of these and ask if like one of them was abnormal, or if that whole thing was normal or abnormal?
Yeah, so eventually on the test, I'm gonna train you guys to, first off, look at your ABIs. So that's gonna be your first indicator, like this one's hard to see, but we're gonna go through case studies before we get to the test and the quiz. We're gonna look at the ABIs. Is the ABI on the right and the left, are they normal or abnormal? So you'll look at that ankle brachial index first. You'll know your normal range and abnormal range. So is there disease? Yes or no, based on that ABI? That's your first step. And then you'll start looking at your waveforms, seeing if they look symmetric side by side. And then you'll also compare your pressures at the different levels. You're looking for pressure drops and comparing pressures at the same level. And that's gonna help you. I'm not gonna give something that's like, so close, you know. Like, for instance, this, you're comparing, like, you can look at the two sides. And you can figure out, like, you know, comparing them, they definitely look different. So which leg has the disease, right or left? So this is right leg, this is left leg. You can tell right away that's the left leg that has the disease. Level of abnormality, they're abnormal all the way through. So I would say the level of the disease has got to be above that high thigh. And then you look down here, this is flat now, that metatarsal, is that digit? Yeah, so. Okay. That's on the great toe, so this guy's great toe is like dead, so it's probably cyanotic. This guy's probably got a dead foot or dead toes.
Well, abnormality, or would you say that the abnormality plus the high side? Where does that info go with the knowledge of it?
Yep, so I would say this is inflow disease because it's above the level of that high thigh. So this is and since it's, and a good point too is since it's just one leg that's affected, it's gonna be his iliac artery. So this would be iliac disease. We're gonna learn when we start categorizing disease, we'll say either iliac or aortoiliac. If you're gonna say aortoiliac, it would have to be bilateral. We'd have to see disease on both legs in order to say aortoiliac. Because again, we can't pinpoint the exact location of the disease. But since it's unilateral one leg, we know it's just the left iliac that's affected. The right side's okay because our waveforms look okay. And our pressures, kind of hard to read those pressures. The pressures are probably okay as well. Yeah, I'm looking to see like 105, 107, 104, 106. It's like you could tell which side's normal or versus abnormal. So I'm gonna have you pick a leg. Which leg's abnormal?
Right.
Yeah. So this looks okay. It's not bad. But yep, definitely, that's where the disease starts. So which cuff is that? That is ankle cuff. So disease has got to be. So calf was okay, ankle was not good. So we have one thigh cuff. They were doing a calf cuff and then an ankle cuff. Yeah, so in the calf somewhere, exactly. Yep. So plethysmography versus Doppler waveforms. So plethysmography is with the cuffs themselves, displacing that air, measuring volume changes. So the waveforms look a little bit different. So these are healthy, plethysmography waveforms. And this is a healthy looking Doppler waveform. So this is using the actual little pencil probe where we're listening to the pulses. With the Doppler waveforms, This is when we can get something that looks triphasic, or when they're healthy, we try and see something that's triphasic. The boards is gonna have you try and differentiate or be able to look at a tracing and tell whether or not it comes from plethysmography versus Doppler. On the boards, that Doppler trace is gonna have a zero baseline, so it's gonna have a line going across it. And you're gonna be able to tell whether or not it's triphasic. It has to have that zero baseline. The plethysmography waveforms do not have that zero baseline on that strip tracing. So that's how you're gonna be able to tell the difference between the two when you're looking at an exam. Let me see if I can find an example. Yep, there you go. So they did a test on this patient. They got waveforms. We know that these are Doppler waveforms because it has that zero baseline going through the image. Versus this. So now we don't see that zero baseline, so we know that these are plethysmography waveforms. So part of my test and my quizzes, I'm gonna have you at least, identify whether it's a Doppler waveform versus a PPG PBR waveform, plethysmography waveform. So look for that zero baseline going across it. So just kind of looking at, I'm just jumping ahead, you can tell right away normal versus abnormal. So it's obvious normal, we expect triphasic waveforms. Abnormal, more monophasic waveforms, but definitely, lower amplitude, they look blunted, getting down to something more significant disease, further down. We'll stop here. I don't want to get into that. Soon you will all be vascular technologists. So we'll pick up next week from there. So we're gonna push our quiz back another week. Yeah, I'm gonna update the syllabi. I'll kind of readjust it, rework it. Bro, you're safe for another week. Look at that and figure it out. Yes.
Yeah, I like this.